Welcome to this BTOG podcast. My name is Stephen Harrow and I'm a consultant clinical oncologist at the Edinburgh Cancer Centre. I'm also a BTOG steering member. This is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their fields and tackle the most important questions that we all face in the diagnosis and treatment of thoracic cancers. It's important to say that sponsors of BTOG do not have any role whatsoever in the planning, content, or delivery of anything discussed. So today's podcast is BTOG Does Management of Cancer Cachexia. So it's a pleasure for me to introduce Dr. Barry Laird, who is a clinical academic at Edinburgh University and a consultant in palliative care. I've known Barry for a number of years, and I know that he is interested very much in this topic. So it's about 11 o'clock in the morning, Barry. I presume you're sitting with a cup of coffee and we're going to have a 20-minute chat about this.
Sounds good. Looking forward to it.
Excellent. Right. So let's start off, Barry. How do you spell cachexia? I've got no idea.
It's interesting, actually, because it comes from the Greek for kakos and hexia, which is bad condition, right? But it's Cachexia is how you spell it. And the correct way to pronounce it is Cachexia, but a lot of people will drop that, the second C.
So, right.
You know, interestingly, Stephen, you and I both sort of trained in Glasgow, and you'll be aware of the cathedral in Glasgow Cathedral. Now, to put Cachexia into some context, Glasgow Cathedral was established about 1,000 years ago, okay? The first description of cachexia was actually done by Hippocrates. So we both took the Hippocratic Oath. And the first description of cachexia was described by Hippocrates about 400 BC. So this is a condition that's been around for 2,500 years almost. And I think it's fantastic that BTOG are, devoting time to this and supporting this cause as they have done in the past. Because as we talk today, Stephen, there is no licensed treatment for cancer cachexia. So it's a really important subject, and it's one of the things that drives me to research it so much.
Okay, so tell me then, Barry, what is it? Like, define it for me.
Yeah, so it's interesting. That's been an area of much debate over the years. So I think the sort of technical definition would be, loss, a condition, complex syndrome resulting in loss of mass, primarily muscle, plus or minus fat mass, associated with reduced function, fatigue, loss of appetite on a background of a systemic metabolic upset. I think we can simplify that definition a bit more. And the most recent definition by a group called ESPEN, the European Society for Enteral Nutrition and Metabolism, would define cachexia as disease-related malnutrition on a background of inflammation. So if we think about, particularly for BTOG, for our people we see who have cancer, we know that the inflammatory response is quite pronounced in these people, and that associated with malnutrition is really cancer cachexia. And it's quite, a key point, Stephen, is really the whole idea of malnutrition here, in that it's not just a simple case of people not eating enough food or taking enough nutrients in the diet. It's as I always say, more fuel in the tank is not the simple answer to cachexia. We have to target both loss of muscle and also target the inflammatory response.
So is this something that is specific to lung cancer, or is this a general thing? Is it more common in lung cancer? What do you think?
Yeah, I mean it's more common in lung cancer. The suggestion is that about it's present in about 50% of lung cancer patients at diagnosis, and about 2/3 of patients will have this, in sort of the latter stages of disease. It's certainly more common in lung cancer and more common in pancreatic cancers. It's less so in things like breast cancer, prostate cancer, and probably colorectal cancer, sort of a middle ground. So my sort of rule of thumb is, it's funny because I still think of it. It's the bad cancers that really get cachexia. So the lung, the pancreas, the upper GIs. And I do think that a bit of that is they're probably a lot more inflammatory cancers. And that's probably one of the main drivers of cancer cachexia.
Okay. And, you know, I can think of patients in clinic that, you know, I would think are cachectic or cachectic, as you taught me how to say it. You know, is there a way of identifying these patients? You know, is it just like I see, you know, quite thin patients who report going off their food? I mean, is that it, or is there a classification system?
Yeah, there's various classification systems really you could use. I guess what I would highlight is the concept of cachexia being a sort of trajectory. And it's argued that it goes through 3 phases. So sort of pre-cachexic phase, where patients may have minimal or no weight loss, but have this sort of systemic, the metabolic upset going on in the background. So you could have somebody, Stephen, quite easily in your clinic who has the pre-cachexic phase, but you just don't see it. They just don't see it.
Do you see it on imaging, Barry? I was just actually thinking as you said that, you know, when patients present and they've maybe had like a chest X-ray or a CT scan a year before or something, is there any evidence that you can actually see that pre-phase?
Right, really good point. Absolutely. So you can essentially. What we do in a lot of our trials is we do what we call CT-based body composition, and it's quite cool. What you can do is essentially look at the anterior abdominal muscle wall at the level of the L3 vertebrae, and you can take the thickness of rectus abdominis, and that you can take that muscle. You use very fancy computer algorithms, and what that gives you is 2 things. It gives you what's called an SMI and an SMD. So an SMI is your skeletal muscle index, so how much lean mass you have, and your skeletal muscle density is the quality of that muscle, how much that muscle is infiltrated with fat. So we can use in our clinics, you do a CT scans on patients. We can actually look at those CT scans at diagnosis and look for evidence of loss of lean mass.
Okay.
But the big problem we have in the Western world, certainly in the UK, certainly in Scotland, Stephen, is that we have this concept called sarcopenic obesity. Now, in Scotland and in the Western world, a lot of our patients are a bit overweight. So they are obese, but they can still lose lean mass, which is also called sarcopenia. So these patients can actually have cachexia, but you don't see it because you think, well, they're a bit fat, and you can't really see them losing weight so much. So it makes it harder to spot in these groups. So that's one of the arguments where we could be using CT-based body composition analysis in routine, lung cancer practice, for example, to try and identify people at the early stages of cachexia.
So are you saying then that people who are overweight, who probably don't report too much in the way of loss of appetite, you can pick up that they're in this pre-cachectic phase on imaging? Yeah,
absolutely. So you can look at imaging, combination of imaging, and you can look at their inflammatory biomarkers, things like C-reactive protein or neutrophil count. And I would the rule of thumb I would say is if you get somebody with a bad cancer, so a lung cancer generally, or a bad cancer, and they've got evidence of systemic inflammation, it's just a case of when rather than if they're going to develop cancer cachexia.
All right, okay. You mentioned biomarkers, Barry. You're quick off the mark there with biomarkers. So can you tell me what are the biomarkers for this? So we've got an idea of what the patient might look like, but we've talked about CT obviously is a biomarker. What other biomarkers are really easier to access?
Yeah, so both ESPN and ESMO advocate the use of what's called the Glasgow prognostic score. Stephen, you and I are aware of that. Obviously Glasgow trained.
Can you explain what that is, Barry?
Yeah, that combines 2 things. Combines CRP, so C-reactive protein, which is a positive marker of inflammation. So the more you're inflamed, the higher that goes. And you've got albumin. The albumin people tend to regard as a nutritional biomarker, but actually it's a negative biomarker of inflammatory response. So as you get inflamed, your albumin goes down. So this Glasgow prognostic score combines CRP, so you've got CRP over 10, and you've got an albumin over less than 35. Essentially, you've got a Glasgow prognostic score of 2, and that's bad. If you've got a raised CRP but your albumin is normal, you would have a score of 1, and if both parameters are normal, your score would be 0. So ESPN and ESMO, what they are saying really now is that in the assessment of cancer cachexia, you should stage this concept of staging the host. Stephen, you do a lot, staging the tumor. We're saying we should stage the host, and by do that, we look at inflammatory biomarkers, as well as the other thing that you do routinely, which is, ECOG performance status. So we think that those two parameters, ECOG performance status and, the Glasgow prognostic score, are a pretty good way of sort of, if you like, framing, staging the host that we see in clinic.
Okay. And who's the person, do you think, in the patient pathway that should be trying to identify this? Where should we, I mean, obviously the earliest as possible, and there's a lots of prehab chat, and we'll not go down that road, but who and where should we be trying to pick up this issue?
Yeah, it's interesting. I think, to answer, the responsibility lies a lot with all of us. So I would argue that sometimes when patients are in clinic, if they're seeing you, for example, the agenda could be, talking about the treatment that's planned, or they want to know more about their disease. And I think there's also been sometimes a reluctance to discuss this problem, because if we don't have anything really to treat it at the moment, no licensed drugs, you can have a big discussion with somebody and say, well, here you see you've lost loads of weight and your appetite's terrible. That's really bad, but I don't have anything for it. Sorry about that. Yeah. It's almost a bit futile. But I think we can mention it, and there are some rudimentary things we think are probably good for managing it. I think responsibility, I think it lies with the whole team. Okay. It lies with, the nurse specialists, it lies with the clinical support workers, it lies with the consultants, and obviously you're big interested in radiotherapy. Nutrition's important in that as well. So I think it's a duty for us all.
So Barry, if I see a patient in clinic and I think they look cachectic, and I do some bloods and I find out that they are inflamed, what do I do? Who do I discuss this with? How can I help this patient? What do you suggest?
Yeah, I mean, I think the first thing you could do is acknowledge it's a problem with the patient. We know from speaking to carers and patients that they like to hear that this is a problem that not just them are having, that it's nothing that they're doing. They're not being sort of strong enough to eat more. I think to acknowledge that. In terms of what you can do, as I said at the start of the call, there's no licensed treatment, but we're doing a trial at the moment called the MENAC study, which is nearly finished actually, and that targets what we think are the three pillars of cachexia, which are inflammation, nutrition, and function. So in that trial, we are giving patients some exercise advice. And that exercise advice is simple, is just do some aerobic exercise 2 to 3 times a week when you get mildly out of breath. So I could say to patients, what I'd like you to do is go for a brisk walk when you're just slightly out of breath for 20 minutes, 2 or 3 times a week. As simple as that. You'll have some patients, Stephen, who maybe already exercise, but doing that. So that's targeting function.
How many times a week did you say? 2 to 3?
About 2 to 3 times a week. So nothing too dramatic. 20 minutes, 2 to 3 times a week. And I try to say to them, build it into the lifestyle. I don't want them to join a gym, but if they go for a walk with a dog, try to walk a bit further or a bit brisker. Or if they walk for a newspaper in the morning, try to just walk a bit longer, for example. So something like that. So that's just targeting function. And targeting nutrition, well, the key here is I call it energy. So it's getting as many calories into the patient as possible. And so the mantra I say to patients is, all your life we've been telling you all the bad things that you shouldn't eat. I'm going to turn that on its head now, and all the things that you've been heard over the years you've not to eat, would like you to eat. So all the things that are high in calories, cheese, chocolate, cream, crisps, fried food, anything that's high in calories tends to be small in size. So what you want is basically to have energy dense food. So energy dense food and high protein food. Now, protein is the main constituent of muscle. So I'll say to them, try to eat as much protein as you can. So, chicken, fish, these sort of things. Optimize your protein, optimize your energy input. And this concept of eating sort of, 3 meals a day, throw that out the window and have smaller meals often. So say sort of 6 snacks throughout the day. So that's number 2, and that's us targeting nutrition. The third thing we're doing in the trial is targeting inflammation. Now, we're using ibuprofen in that study. Now, at the moment, I couldn't say to you, Stephen, you should prescribe ibuprofen for your patients with cachexia. But that's something that when the trial's published, if it's positive, we would see that these 3 pillars of targeting function through exercise, targeting nutrition through an energy-dense, high-protein diet, and targeting inflammation through simple ibuprofen would be almost the backbone of care that we would hope could be applied to all people with lung cancer.
Okay.
So I think in a clinic you could spend 5 minutes just saying there's 3 things you need to do: exercise, food, or 2 things: exercise and food at the moment. And if you can do that, is key. And I always think it's important to get the caregiver, the partner, get them on board and give them a purpose as well.
What about supplements, Barry? Quite often we have this issue in clinic. I don't know if this is across the UK of who's going to prescribe supplements. Is it the GP? Is it us? How do you get access to them? Do you need to go through a dietitian to get them? What about just giving everybody supplements?
Yeah, so really good question. Actually, you can prescribe them. The GPs can prescribe them. Number one, the supplements we have in the NHS are generally what we call 1 kilocalorie per mil. They come in a 200 ml bottle, and it's the same as 200 mils. So it's not, in terms of calorie intake, it's just calories really. It's not much difference to taking a full strength sugar fizzy drink, for example, in terms of calorie intake. But if patients find them palatable and they're which softening they don't want, if patients like the taste of them, then it's a good way to get extra calories in. They're just an energy dense way of nutrition.
So if they didn't like them, and lots of people don't like them, you can just say, have a can of fizzy juice or. Right.
I mean, anything, because it's the same. A can of Coca-Cola is 130 calories. If you take a 500 ml bottle, it's 200 calories. It's the same as what's in a nutritional drink.
Is it? Okay, I didn't know that.
I mean, they have other vitamins and things in them, but there's no real evidence that they make a dramatic difference. Mm-hmm. Just to point out, there's some supplements, they're not available in the NHS, have omega-3 in them, which are fish oil supplements. Mm-hmm. Now, we're using them in our trial, but we think that the omega-3 in these supplements is an anti-inflammatory. So we think that's another way of targeting the inflammatory response. But again, the evidence doesn't support that at the moment. It doesn't not support it, just doesn't support it yet.
Okay. And what about other things that you can use? I mean, we in the past have prescribed kind of progesterone type drugs. I don't prescribe them anymore because I kind of never really. Well, it was always kind of end of life stage that you would prescribe these to patients. So should we be using these drugs? Are they valuable? Should we be using them earlier?
Yeah. There's two big groups here. There's megestrol acetate and there's dexamethasone. So my short answer to this is no.
All right.
And I'll go through one at a time. Dexamethasone is useful in short term, and you'll give it alongside some emetogenic, systemic therapies, etc., and that's fine. But what we know is that use long term, dexamethasone causes actually loss of lean mass, loss of muscle, which is what we are trying to prevent in cachexia. So a short sharp shock occasionally is okay. Long term use, I would tend to avoid, except for patients near the end of life. Megestrol, limited evidence it works, but it makes people hungry, but doesn't really do any other effects on them, and there's quite a high risk of blood disorders with them. So, like you, I don't really prescribe megestrol either.
And is there evidence that if you give somebody steroids for like a short period, what you're talking, a week, 2 weeks, that actually that does kickstart their appetite, or?
It can make them a bit better for a while. There's not really any evidence that once they stop, there's a sort of refractory loss of appetite again.
Okay.
So
that's what I would have thought, but I just wondered whether or not actually it does kind of kickstart something, but you don't think so? I
don't think longer. It will help them for a week or so, and then it will wear off. And then the next time you give it, the effect is diminished.
Okay.
And I always say to patients, it's not just about the muscles. It's not just about the muscles in your leg. Your heart's and muscles. It's your intercostal muscles. And we know that when people have got low levels of muscle, their toxicity to systemic therapies is much higher.
Okay. So, and what about the cannabis oils? the things that we get asked about quite a lot that I don't think any of us really know too much about.
Yeah, so the cannabis oils, interestingly, the preparations that people can buy either on the internet or on high street shops have got such low levels of CBD in them that they're almost pointless. So I would avoid against them. NICE don't advise them either.
Okay.
But, and in Edinburgh and a couple of centres in the UK, we're doing a phase 1 trial of an oral cannabinoid for cancer-related anorexia, and that's what we call pure CBD1 and 2 agonists. So it seems to improve appetite in healthy volunteers. So potentially, that's high concentration of CBD, and that may improve appetite. But that's a trial that's ongoing, and if positive, that could be something we could have in our toolbox, if you like, to help improve appetite.
So that's quite interesting. So you think we are able to tell patients really these aren't strong enough to have an impact and actually go and have a can of Coke instead and a cream bun?
Correct. Absolutely.
Okay.
Right. And the flora spread has to go, and it's butter again, and it's cream. It's cream. Throw out the sweeteners. It's sugar in the cups of tea and coffee. It's just getting energy into the patient. But the key thing is, if you just give people calories and they don't exercise, they just get fat. So what you have to do is give people calories and get them to do some exercise, and then you get a thing called postprandial anabolism. So that results in anabolism, which is buildup of muscle, and that's what we're trying to do.
Okay. So Barry, we're nearly coming to the end of our 20-minute chat. I'd quite like at this point just to ask you, is there something that you'd like to tell us that I haven't asked you? Is of hot off the press interesting?
Yeah, what I would say is that although there's no treatment at the moment, the cachexia sort of landscape has really improved in the last 10 years. There's lots of trials in development or running at the moment. So, if you're in a centre in the UK or elsewhere, and you've not got a cachexia trial in your lung cancer portfolio, Stephen, in Edinburgh, we're fortunate to have several trials there. If you've not got a cancer cachexia trial in your portfolio, reach out and ask why, and get that point so that all patients can potentially have access to that.
And would it be palliative care teams that centres would reach out to?
I actually think the cachexia has been the remit of palliative care for a while, but a lot of palliative care is almost end of life care. But by that point, the ship has sailed. So I actually think I think oncologists are the ones that should be, dealing with this. So, or at least well versed in the trials that I'm running in the UK, with the exception of 2 sites, they're all run by oncologists, and I think there's been a real positivity. BTOG have certainly helped, but the real positivity amongst oncologists now that they see this as not just a handmaiden, but an actual critical part that influences the efficacy of therapies. And I would say to finalise this, we talked about staging the tumour, and I said stage the host. So we need to stage the host, and just as you treat the tumour, Stephen, in your clinic, I would say we treat the host as well. So stage the tumour, stage the host, treat the tumour, treat the host.
I think that's true, because I think that the cancer cachexia, the way patients look is such a stigma associated with it,
correct.
And identifies them very much as lung cancer or cancer patients. And I do think we underestimate how patients feel within themselves and how they feel when they present themselves to the public about that. And I think if we can help that, then it would be a good thing.
Absolutely.
Okay, Barry, well, look, thank you very much for taking your time out today to have this chat. Hopefully that's been helpful to people who look after and deal with lung cancer patients, as well as actually patients themselves if they're listening as well. So thanks everybody for listening to this podcast. We hope that it's given you an insight into the management or the issue of cancer cachexia and the management of it. For more information on BTOG, including educational events and how to join, you can visit www.btog.org.